Off or type it in. What is the first thing that comes to your mind when you hear the word menopause?
Liberty, freedom, lack of restraints. Yeah. Oh, I like those.
I like those too.
What about you?
I was thinking bone density loss and just hormonal changes that might affect functioning.
Okay, if we go that route.
I like
breast,
yours much better.
breast cancer, there has been some association between menopause, the percent of fat tissue that women have, and the recurrence, the prevalence of recurrence of that cancer 10 years after the diagnosis. So you can think about that. Yeah.
We have it up. Okay. So we're gonna get started. So happy to be here. I know this was a topic that was requested for me to present on, like happy to return again. Last year I presented on the anti-obesity medications, and so this was the topic that was requested. And I heard Guari was focusing on menopause, so hey, why not have the specialist, the endocrinologist, who's definitively the expert on this.
Thank you for inviting me.
So that's how we're both here together, and this is a topic that comes up very often in with my patients in primary care. All right. The clicker's not working.
Is it on? Did you push the side button? Is it on?
That was off. No, it's off.
Yeah, just make sure it's on. And maybe point it towards the computer. Oh, that's a bottom.
Right, it's not working.
Okay, I'm gonna have to do it
Advance the
manually.
slide then.
Well, what do you think about when you think about menopause?
It's
Hot flashes.
Oh, I like that one. Hot flashes. Anybody else?
and any other burning questions right off the bat before we get started that we make sure we get to today through the presentation.
Dyspareunia.
We'll make sure we address it.
Okay, and just so we get started, we have to make sure, just want to let you know, neither of us has any disclosures. Maybe.
No disclosures.
All right. Next. First, we're going to start talking about the staging of menopause.
Yep, staging of menopause and the physiology.
Then I'll talk about the cardiovascular risk stratification.
Management of vasomotor symptoms and the genitourinary syndrome of menopause.
So she's going to talk about the hormonal. I'm going to talk about the non-hormonal.
Bone health.
And I'll finish with skin health. Next. All right. So menopause across cultures. So before we dive deep into this topic, I want to talk to you about give you a global perspective of what people think of as menopause, because it's experienced and viewed differently across the globe. And while Western culture looks at it more in a more medical sense, and also with a more negative connotation of like, hey, you're over the hill, useless, a lot of symptoms, hot flashes. Other parts of the world, for example, Japan, they don't even very few experience menopausal symptoms. They did not even have a word for hot flashes until very recently. Their word for menopause is, not sure I'm saying this right, koneki, which means the term renewal and regeneration. and they view it more as a time period, 40 to 60 is a time period of rebalancing and a period of renewal. So they focus on those types of, hey, your body is going through changes and you're trying to find a new balance and trying to find a way to regenerate and renew. And then also in cultures such as in Native American cultures where, basically in cultures that when menopause is celebrated, women look forward to this milestone, because you cannot become a shaman or a healer in Native American cultures until you have become wise and you no longer losing the wisdom through that, and you're keeping it, maintaining it. So in those cultures, they actually look forward to menopause. So this, so basically, before I get started, when you're thinking, before I delve into the details of it, just think about approaching anyone without having any preconceived notions, and also trying to look at the positive sides of it. Next. So this is just an image overall of how much estrogen our body has throughout our lifetime, and where it is starting. It rises during puberty, have our cycles, during menstruation, goes up higher during pregnancies, and then it dips down during menopause. The average age of menopause is 51. And when you're looking at this, just take a look. We're spending 40% of our lives in menopause with the average life expectancy. So just something to keep in mind while I hand it off the details to Guari here.
Thank you. All right, so this is where the endocrine nerd in me comes out. So I always like to tell people about the phases of the continuum of a women's health journey. And if we divide them into the reproductive years, a lot of times we talk about reproductive years and postmenopausal, and we think of it as a dichotomy between the two. But I like to challenge everyone to think about it as 5 different phases. So reproductive years, the early transitions of perimenopause, the late transition of it, menopause itself, and postmenopause. And as Dr. Nachiappan said, the mean age of natural menopause is 51 years old, but 90% occurs between ages of 45 to 56. So there's a long period of time where this could happen for most women. And we also need to remember that premature menopause or premature ovarian insufficiency is when those changes occur before the age of 40. There's some important distinctions. One thing that I always try to remind patients and other clinicians is we talk about menopause as a very long period of time, but menopause is technically one specific day. That day occurs exactly 12 months after your final menstrual period. So when we talk to patients, it's really important that we teach them the correct terms. We're talking about perimenopause, or if you want to say hormonal transition, if that's too complicated, a hormonal transition, and then that transition still continues after menopause. So after that one day, that transitioning is still occurring for up to 8 years after that one day. That's why postmenopausal things look different on the first day after menopause, all the way to 5 or 6 years later. And so once we really clarify that with people, that people realize that this transition takes place over 20 to 25 years for most women. Go to the next slide. All right, I put this here, but I'm actually going to go into it in a lot better detail because I'm more of a colors person, as I'm sure some of you might be able to tell. So we'll go to the next slide, and I simplified it a bit better here. So the Stages of Reproductive Aging workshop that occurred in 2001 came up with a staging system, and then they went back 10 years later and updated it in 2011. That's what STRAW plus 10 means. And so this is the complete staging system. You've got 7 stages across 3 phases. Reproductive is, and the time point that determines what stage you're in is menopause, which is at stage 0. So everything before stage 0 is in the negative stages, and everything after is the positive stages. So I'll just draw your attention to stage -3 for late reproductive stage. That's when people are starting to have changes. So they have regular cycle, but subtle changes start to occur. And those changes start to occur because FSH starts going up, AMH starts coming down, inhibin B starts coming down, and your antral follicle count starts coming down. And a big thing I want to point out here is a lot of people think that the reason FSH goes up is because our estrogen goes down. It's actually because the antral follicle count goes down. So we have less of those granulosa cells that are producing inhibin B. And so less inhibin B means that our FSH is going up, and that's what cascades a lot of these changes. And that's really important to note. The other thing I'll note is in that menopausal transition, these are things we already know about, right? First, the cycle length starts varying, then we start having longer time between cycles, FSH goes up, estradiol comes down. But I want to point out the early stages of postmenopause, because you can see a variation on what it's like the first 2 years, years 3 to 6, and then after that. And so it's really realizing that there's such a change of symptoms that's occurring. And so how you treat it on day 1 of postmenopause and how you treat it on year 3 of postmenopause can be different. We'll go to the next slide. Okay, so when we talk about straw plus 10, one thing is this whole criteria, if you think about it, is really using clinical criteria. So it's using menstrual cycle criteria as the principal staging tool. So the limitations are that on people who may have an abnormal cycle. So thinking about people on hormonal contraception, because now you're looking at what's occurring for cycles based on their hormones that they're taking. Those that have had a hysterectomy but still have their ovaries, and transgender men on testosterone. Big thing to note here is that the biomarkers are supportive, not required. And a big other thing to realize is that a lot of that is due to the assays lacking international standardization. We'll go to the next slide. Okay, here are the systemic physiologic changes that occur across the transition. A lot of us know the really common ones, right? So we'll start with, your follicle pool gets depleted, 1 million at birth, down to 1,000 at menopause. Your anovulatory cycles increase, progesterone falls. Your estradiol drops about 85% over the 2 years before and after your final menstrual period. And then your postmenopausal estrogen is primarily estrogen from the peripheral aromatization of adrenal androstenedione. So we know about our cardiovascular effects. We've got the loss of estrogen's vasodilatory and anti-atherogenic effects. We know our LDL goes up, HDL goes down. We have an increase in central adiposity and insulin resistance, and then endothelial dysfunction accelerates. At a skeletal point of view, I think one of you brought it up, that the estrogen loss leads to accelerated bone loss, and I have more slides on that at the end. And then this one, the neurologic and thermoregulatory changes, you've got a narrow thermoneutral zone that leads to your vasomotor symptoms. Estrogen modulates serotonin, norepinephrine, neurokinin B, or your candy neurons. That's a lot of why we use SSRIs and SNRIs for vasomotor symptoms for non-hormonal therapy. You've got changes in hippocampal function that leads to cognitive symptoms like your brain fog. And then the sleep architecture gets disrupted. A common misnomer is people think it's because of the hot flashes, but there's actually independent changes that occur with sleep independent of those vasomotor symptoms. Thank you. So hot flashes, night sweats, they affect 50 to 80% of individuals. They're most pronounced in the first 4 to 7 years, and the median total duration is 7 or more years. We've got the genitourinary syndrome of menopause, so your vaginal dryness, burning, dyspareunia, dysuria, urinary urgency, recurrent UTIs. That affects, half, again, the same kind of numbers, half to 80% of postmenopausal women, and it's progressive without treatment. It's why a lot of women get to a really severe place before they even tie it back to their hormones and hormonal transitions. And then other common symptoms are the sleep disturbances I mentioned, mood changes, cognitive changes, decreased libido, joint pain, and then your increased abdominal fat and adverse lipids. One thing to know is that some of these symptoms are highly prevalent across all the stages. It doesn't have to just be postmenopausal or perimenopausal. It could occur during the whole time. Next slide. In terms of diagnosis, no routine labs are needed. Menopause is confirmed retrospectively after 12 months of amenorrhea. FSH and estradiol are not recommended for routine diagnosis, and someone who is a typical age for this transition because the hormones are always fluctuating, so it wouldn't be very helpful for you clinically anyway. So no routine lab testing is required for patients aged 45 and older with classic symptoms. Where you would want to check those Those hormones are in patients who are age less than 45 with suspected premature ovarian insufficiency. They're on hormonal contraception, transgender men on testosterone, or an atypical presentation requiring workup. One thing to know is we would definitely want to rule out thyroid disease, hyperprolactinemia, and there was one more, pregnancy. That's a common one. A lot of women will think that they're going through the hormonal transition and they're actually pregnant. So don't forget to check that. All right, next slide. You want to go on here?
All right, before we get to the cardiac risk stratification, I just want to, as an internist, let me just give a quick overview of mortality rates in women across all ages. And I know breast cancer gets a lot of publicity, but if we really look at it, the number one cause of women's mortality is cardiovascular disease, whether it's coronary artery disease or stroke. They, if you look across the whole time span, they are the number one cause. And obviously it goes up significantly after menopause, but even before menopause, this is the number one cause, and that needs a little bit more attention. The treatment of that is nothing sexy. It's just it's blood pressure, insulin resistance, lipids. These are the standard bread and butter internist things that we manage, that need to be managed, and obviously across the whole lifetime. And so just to give a perspective, a woman is likely to die of from cardiovascular disease in one out of every 2.5 women will die from cardiovascular disease, or 40%, versus 1 out of 30 women will die from breast cancer, just to understand relative risks. And okay, and then we can, obviously the rest of the breast cancer, colon cancer, endometrial cancer, much lower down. Oops. And so before discussing cardiac risks, let's take a look at pregnancy. If your patient has been pregnant before, that is the biggest stress test they could have undergone. Obviously, that was earlier in their life, but if they ever experience anything adverse during their pregnancy, then this is a very big indicator of a higher risk of future cardiovascular and metabolic risk. So take a very thorough pregnancy history. If they have gestational diabetes, preeclampsia, pregnancy-induced hypertension, pregnancy complications, premature ovarian insufficiency, autoimmune disease, smoking. Next. So, and when we're looking at risk factors, we have the traditional risk factors that we already touched on: metabolic syndrome, diabetes, inactivity, hypertension, dyslipidemia, but we also have the non-traditional risk factors that we need to keep in mind. Baseline inflammation, anti-inflammatory response, critical illness, autoimmune disease, adverse pregnancy outcomes, and hormone replacement therapy, as well as the mental health issues like depression, stress, poor sleep, and genetic predisposition. Next. So before us, okay, as a caveat, if a patient presents with menopausal symptoms, you want to be offering treatment right away, symptomatic treatment right away. As far as going down the risk stratification, that's to make a determination of whether you can go down the hormonal treatments or not. But you want to start treating the symptoms right away. You don't have to wait until you're done with assessing their risk. But basically, I mean, you can look at this later in detail. Low risk, this is the ideal. If they had blood pressure, normal blood pressure that's not treated, normal weight, and you do the prevent score to make sure it's low risk. And then you have intermediate risk and high risk. High risk being if they already have cardiovascular disease or cancer, or greater than 10%. So next slide. So now if you have the intermediate risk, this is another way to help sort the intermediate risk category. You can also do a CAC. Take a look at the CAC scoring, because you can see when the score goes higher, the number of coronary events goes up higher significantly. That part seems to have gotten cut off, but that's basically why we want to take a look at it. So if they're intermediate risk, you want to use the CAC score, and that helps you determine if it's 0, then hormonal treatment is fine. Then if it's 1 through 99, you want to use lipid lowering medication and transdermal estrogen treatment. If it's over 100, do aspirin, lipid lowering treatment, and transdermal. And if it's over 300, you'd want to avoid hormones. Next slide. And this is a great chart from the study to take a look at, hey, if they're low risk to begin with, hormone therapy is fine. No, and basically it's years since menopause onset. If it's less than 10 years, it's fine. If it's over 10 years, then you got to take a look for everybody. If it's already been menopause, has already been more than 10 years, you want to take a little closer look before initiating hormones. But if it's less than 10 years, no, and low risk, no, nothing to worry about. Intermediate risk, you can do transdermal hormonal therapy, assuming nothing else significantly. And then high risk, you generally want to consider alternative therapies instead of hormones, non-hormonal therapy. And if it's greater than 10 years and high risk, this is the category you would definitely avoid hormonal therapy. And so here's a summary slide showing the cardiovascular health. Cardiovascular disease is the leading cause of death in premenopausal and postmenopausal. So management, we already discussed, it's lifestyle, healthy diet, weight optimization, smoking cessation, adequate sleep, and the medical management optimization with statins based on the ASCVD score. But you need to remember, hormone therapy is not recommended for primary or secondary cardiovascular disease prevention, for USPSTF. And the current indications, these are the 4 indications currently approved by the FDA for menopausal hormonal treatment: vasomotor symptoms, vulvovaginal atrophy, osteoporosis prevention, and hypoestrogenism, which could be due to any of the reasons, whether it's surgical menopause, premature ovarian insufficiency, hypogonadism, or premature menopause. So I'll hand it off to Guari. Yes.
All right, thank you for that introduction to hormone replacement therapy. So a big number that I always try to point out to people when they're avoiding hormone replacement therapy is that you can impact 75% of a woman's quality of life by treating them. I know we're really scared of it, and I know it comes from an old study that was, I shouldn't say old, but a really landmark study from the Women's Health Initiative, which I'll talk about in a little bit. So I won't repeat what Dr. Nachiappan said about candidates for hormone therapy, but key principles, we want to go with the lowest effective doses, the shortest duration consistent with treatment goals. We want to make sure we do periodic reassessment of continued therapy need. And a big thing to remember is if a patient has an intact uterus, it requires progesterone with estrogen. And if there's no uterus, then you can give estrogen alone. Routes of administration, there's so many different options for patients. So oral and transdermal estrogen have similar efficacy for vasomotor symptoms. Transdermal is preferred if they have VTE or stroke risk factors. That doesn't appear to increase VTE risk above baseline. And so now we have available patches, gels, sprays, vaginal rings that are systemically dosed. Go to the next slide. And then contraindications to systemic hormone therapy include unexplained vaginal bleeding, active, or actually Dr. Nachiappan went through this already, so I'll skip this slide. Okay, so I want to go through the history of hormone therapy prescribing. So the y-axis here is hormone therapy prescriptions per year by millions, and the x-axis is the year. So let's do a little history lesson. So back in 1942, conjugated equine estrogen was first introduced. 1975, we discovered endometrial cancer risk. And you can see that prescriptions first went up. We discovered that prescriptions went down. Then in 1980, we realized, okay, let's combine estrogen and progestin. That came up, so prescriptions went up. And then in 1990s, we had our nurses' health study and the PEPI published. Prescriptions went up. In 1998, the HERS trial gets published. And then in 2002, the Women's Health Initiative gets published. And that study showed a lot of things. And unfortunately, some of the things that it showed got blown out of proportion by the media. And that really impacted prescribing. And you can see a very steep decrease in prescribing of hormone therapy. We'll go to the next slide. All right, so let's talk about the findings that they had and what actually occurred during the study. So the mean age of women in the study was age 63. What was the age that we talked about as the mean age of women going through menopause? 51. So the mean age of the women here were more than 10 years older. And so that really wasn't reflective of our typical hormone therapy replacement candidates. So for the women that were ages 50 to 59, that's our key demographic, right? So we gave them both the conjugated equine estrogen alone and conjugated equine estrogen plus MPA, which reduced vasomotor symptoms without significantly affecting atherosclerotic cardiovascular disease risk. That's really important to know because we showed in the right age, that's okay, you should have the candy. We show at the right age that it reduced symptoms without affecting CVD risk. And then for patients age 70 and higher, it increased ASCVD risk significantly. And that's where we came to the conclusion of hormone therapy should not be initiated at age greater than 60 or more than 10 years post-menopause. There are exceptions to that. So don't make that a hard and fast rule of absolutely no, you're not going to do it. But this is where you need to be intentional and weigh out risk versus benefit for that population. So the bottom line for recently menopausal women, symptomatic patients without contraindications, hormone therapy has a generally favorable benefit to risk ratio. And I think it's really important that all of us as clinical leaders, that we make sure we're up to date on that information and we correct all the misinformation that's been out there for over 20 years. Go to the next slide. All right, non-hormonal options for vasomotor symptoms. Nachiappan.
So if your patient's not a candidate or they're not interested in hormone therapy, or you just want to get them started while considering that, some of the things that you can start with is like paroxetine, which is the only non-FDA approved, the only FDA approved non-hormonal therapy is paroxetine, with 10 to 25% reduction in symptoms of vasomotor symptoms. It really helps, the SSRIs help stabilize the thermoregulatory centers, and that's how it works. And venlafaxine also has really great efficacy because you would want to consider venlafaxine if somebody's on tamoxifen. You cannot use paroxetine and you'd want to use venlafaxine instead. And it has very good efficacy even if it's not FDA approved. And the newest one is the fezolinetant, which is works on the KISS, the neuropeptide.
Yep. This is really exciting because it's actually one of our most, in addition to paroxetine, it's one of our most effective medications for vasomotor symptoms. That's not hormone based, but it's actually addressing the root cause at that neuropeptide level. So that's really exciting. There is an FDA black box warning about liver studies, and so you have to do close monitoring for the first 9 months that you put someone on it.
Yeah, the evidence, the studies look amazing as the latest and greatest non-hormonal therapy, but I haven't actually had any of my patients start on because of the cost. Well,
yeah.
Also, it's not covered yet. But the other one, next one, gabapentin. This has been, it's great for sleep disturbances. For patients with sleep disturbance, gabapentin is a great option. And oxybutynin also has been found to be significantly pretty good, but we also have to balance the risk because it's on the Beers list of concern for delirium. So Then some of the other things we can consider is cognitive behavioral therapy, clinical hypnosis. Again, these are limited by availability of mental health therapists. And I know many of these other ones, we hear a lot on social media about some of these things like black cohosh, but it doesn't have, none of the other things actually have any studies that have held up. But it's still good to know some things like acupuncture, phytoestrogens, like, which is basically eating a plant-based diet with a cup of soybeans for the meals. And it was only a study with 40 women in China.
Yep.
And then they found that it reduced their symptoms. But sometimes if your patients are very much interested in other options, this is something you can refer, but do we have great evidence? No.
Yeah.
Next.
Okay, so I put this controversial slide in here on purpose. Because I can tell you in my clinic, I get a lot of people asking me for compounded hormones, and they use compounded and bioidentical interchangeably. So I put this in here. Let's talk about the terminology. So where the terminology came from is our first estrogens we were using were conjugated equine estrogen. And so when we came out with more bioidentical estrogen for people to use, that's where the term bioidentical came from. So this concept of bioidentical equals compounded, that can be true. Compounded can have bioidentical hormones in it, but that's not the only source. So we have FDA approved bioidentical hormone therapy. We've got estradiol, which comes orally, transdermal, gel, sprays, vaginal forms. We have micronized progesterone that comes in 100 to 200 milligram oral formulation, which may carry lower VT and breast cancer risk versus synthetic progestins, which I'll get to in a bit. And then combination, which is estradiol, 1 milligram, progesterone, 100 milligrams, FDA approved for moderate to severe vasomotor symptoms with an intact uterus. So the big thing to know is bioidentical hormones have been rigorously tested for safety, efficacy, potency, and pharmacokinetics. They're FDA approved. Now let's talk about compounded bioidentical hormone therapy. So these are custom mixed by compounded pharmacies. They're not FDA approved and not subject to the same regulatory oversight. So there's not a lot of evaluation for safety, efficacy, or quality, and dosing can vary. So estradiol can be 26% below label, progesterone 31% above label. They're missing standardized labeling for contraindications and adverse effects, so a lot less information given to your patients. And they're marketed as natural and safer, and those are not supported by controlled studies. So I bring this up because I can't tell you, I mean, I even have like really good friends that chose to pay for online, an online hormone specialist that gave them compounded hormones. They pay cash out of pocket, $400, $500 a month. I just posted about this actually. They'll get their labs back. They'll be like, hey, Guari, can you look at these? And I'll be like, well, your estrogen's undetectable. Your testosterone's 3 times the upper limit of normal. I don't know if this is the best way for you. Maybe you should consider seeing someone, that can prescribe hormones in a safe way for you. So it's really important that we acknowledge there's go to the root cause of what happened rather than making, someone maybe feel bad. There's probably a reason why they went to that hormone specialist in the first place and got on compounded hormones. So really understanding what was the gap, what was the underlying reason that made a patient go this route, and what are they afraid of with typical FDA approved medications. Now, I will say there are situations where compounded hormone therapy is appropriate. Someone's allergic in something that's there. Maybe it's somebody who's afraid. Some formulations of progesterone have red number 3 in it. And if you have an allergy to it, this is where you go compounded or to another form. So just make sure that when you approach it with a patient, you understand what was their why and try to help them feel more comfortable and confident with what they're taking. And if they still choose to do it, let them know the harms and the risks. And then you just know that they may have some bad things happen. And as long as they know that that could happen, then that's their decision to make. Go to the next slide. Pellet therapy and salivary hormone testing. Us endocrinologists love these. So pellet hormone therapy, ACOG recommends against it. It has significantly higher side effects rate versus FDA approved hormone therapy. We're talking about 57.6% rate of risks or side effects compared to 14.8%. So really big risk. It's important we tell that to patients. You know, they can lead to superphysiologic estradiol levels, superphysiologic testosterone levels. 55% of women with an intact uterus had abnormal bleeding, and then 20% ended up going through hysterectomy. The one key thing is that it can't be removed once it's inserted. You have to wait months for it to dissolve. It's really interesting to me because a lot of the patients that want these are all about like natural therapies and wanting to trust their bodies and things like that. And it's so interesting and fascinating to me that they want to get a pellet, given that we can't reverse it, we can't take it out, anything like that. So for me, it's interesting. Again, I try to go to what it was. Why did you choose this? What was the thing that you were trying to solve? What are you afraid of? Let's go through it together. And then salivary hormone testing, a lot of different clinicians have been recommending salivary testing or promoting it. It's often sold as a package deal. You get your testing, your hormones, your visit with your provider, pay X amount of dollars all in one. And I wonder how much of it is that they've just made it so easy that they don't have to go through insurance, they don't have to go through prior auths, they don't have to go through, I wonder if it's just here's a package, we do everything for you, don't worry about it. But the ACOG states that data on interpretation of adjunct hormone tests for prescribing compounded hormone therapy are limited, and these tests are not recommended. And then FDA-approved hormone therapy, we dose it based on symptom response, not hormone levels. And so that's another thing to let patients know, is that when we're treating you, we're checking hormone levels to make sure you're not on too much of it. But how we decide whether we continue it or not is actually based on how you're feeling. So the bottom line, offer FDA-approved bioidentical hormone therapy first when patients request bioidentical or natural hormones, because that's what they are. Reserve compounded hormones for documented allergies or some other reason, just make sure you document what it was. I've been telling patients you should know why you're going on compounded therapy and not bioidentical hormones, because that at least gets their minds thinking of like, I should understand why I'm on this and not on something else. Avoid pellet therapy and don't use salivary or serum levels to guide compounded hormone therapy dosing. Next slide. Okay, micronized progesterone versus synthetic progestins. Okay, so going back to the Women's Health Initiative, do you guys know which progestin formulation they used in the study? If you're thinking MPA, you're right. Yay. Okay, so when we talk, I put this slide in here so we can compare both of them to each other. So breast cancer risk, no increased risk in the first 5 years with micronized progesterone, a modest increase with prolonged use compared to a significant increase with MPA. VT risk is neutral for micronized progesterone compared to an increased risk with the synthetic progestins. Lipid effect is neutral to favorable versus MPA can attenuate estrogen's beneficial HDL effects. Blood pressure, no significant effect on micronized progesterone, and it may increase systolic BP in some studies. What I want to get to, key thing is the level of evidence here. So synthetic progesterones have been studied a lot in the Women's Health Initiative, which was a massive randomized control trial with MPA in it. We have a lot of data for that one. So we have lots of proof of all the risks and problems with it. I'm saying all these positive things about micronized progesterone, but the key thing to know here is that this is based on observational studies. We've had no dedicated RCTs for hard points here. So just know, even though you're going to be drawn more to that, just like I am, just know that we're basing that off of what observational studies have shown us. So the evidence, basing your decision-making on evidence alone is not there. There's one that's clearly more effective, but if you're going off of observational studies, there's one that's clearly better. We'll go to the next one. I will also say that's a plug for how important it is that women's health gets studied and researched and prioritized, and really appreciate all the recent attention on women's health and perimenopause and postmenopause.
Okay.
Go back. That was my bad.
So, one of the questions that we had was regarding the GSM, which is a new term that they're using for gender urinary syndrome of menopause. Basically, where you end up with the changes that are happening, you end up with mucosal thickening, urethral shortening, having a lower bladder storage capacity with a larger post-void residual urine with menopause. And what happens due to some of the vulvovaginal atrophy that happens, as you can see, with the epithelium cells getting thinner, making it harder to maintain the barrier. And also with the lower sphincter tightness. So the first line therapy for it is two varieties, is either for the mild symptoms. First line would be either vaginal moisturizers or which are hormone-free moisturizers, which are non-inferior to estrogen-based for mild symptoms. And then you have the vaginal lubricants as needed for sexual activity. And before we go into this, I know you kind of touched on it earlier, but something, just the epidemiology of it is that about 50% of menopausal women experience GSM. And of that 50%, only like 6 to 7% are actually receiving therapy for GSM. So even those that are experiencing it are not receiving much therapy. It is progressive, and we need to be better addressing it with our patients and taking care of it. Next slide. So I'll start with the one that I mainly use, and then you can jump in for the other two. Topical vaginal estrogen. And I think recently the FDA even discussed not needing a prescription for it because it is that safe. And this is something we need to encourage our patients to use, even if they're using systemic estrogen therapy. Even using local topical estrogen is good because it lowers the vaginal pH, thickens the vaginal epithelium, it increases the superficial and the subepithelial cells, and basically alters the local microbiome. And it prevents, there's been many studies where it's reduced the amount of sepsis, urosepsis in women if they're on topical estrogen cream. So this is so important. If there's only one thing you remember, I ask you, this is so simple, and it should be offered if they're experiencing even any moderate symptoms. So do you want to jump in?
Yeah. I'll also add that if you want to go back, I'll also add one thing that we often forget is our embryology classes. So our bladder cells come from the same embryonic tissue as our vaginal cells. And so they are very sensitive to estrogen as well, which explains why we get so many of those genitourinary symptoms, in addition to the vaginal dryness and issues like that. So I think it helps me, at least when I'm taking care of a patient, to tying it back to things like that. So now I will think about, oh yeah, bladder and urinary symptoms are very common here. You can give these other two options, vaginal DHEA. There's a 40 to 80% improvement, but there is an adverse effect of vaginal discharge. So this gets discontinued pretty frequently by my patients. And I haven't had that many go on it because the low dose vaginal estrogen actually does wonders. And then there's oral ospemifene, which is a SERM. I actually haven't had to prescribe this because I've had success with other drugs, but this has 30 to 50% improvement. It's the only oral option for genitourinary syndrome of menopause, and it can increase symptoms for that first month. That's the main reason. When I explain this to patients, it's no, I'm good. I don't need to go on that one. That's it for that.
Okay. One more thing. The other important thing with the vaginal estrogen is that you don't need to worry, even if they have a uterus, you do not need to have progesterone. Yes, there have been concerns, hey, can it increase the serum estradiol? But all the studies, they've had many studies on this one, and there's been no adverse effects, even if they're not on progesterone. So it is extremely safe, highly recommended. But also the other thing that I assumed we wouldn't have time to include is the pelvic physical therapy for it is amazing, because it really is effective. It's one of the things, like, simple things to remind is do not squeeze the bladder when you're going to urine, like going to the bathroom. When you're urinating, don't squeeze, just relax, because that is an important aspect. And I can attest to it personally because I assumed I had a third child. I'm like, that's why it's weak. I haven't hit menopause, but it's still like I was experiencing the same thing. But then since I've been learning about more of the menopause and doing the physical therapy, and one of my friends who's never had any kids was also having similar symptoms, again, before hitting menopause. So you start experiencing some of these symptoms even before it happens. And then like, all right, let me try some of these methods. And lo and behold, yes, and I could sleep through the night, and I assumed it's all because of this. So you know, when you think it's because of something, it's very easy to be like, oh, this is just gonna happen. So I was like getting up multiple times a night. And when you force your bladder to hold, like squeeze when you need to, like all you have to do is sit at the edge of a seat and like imagine like a jellyfish, lift up, squeeze for 3 seconds and relax. And then squeeze for 3 seconds, relax. But the only time you squeeze is for holding. And when you go to the bathroom, no squeezing. You just have to relax and wait for it to come out. But the amazing, like sending them to pelvic physical therapy is amazing for GSM, blood bladder symptoms, and their sleep. So yeah, that was an aside.
No, I love it.
I'm going.
You know, I will also say, because there's not a lot of pelvic floor physical therapists, it's important to know who is in your area for your patients so that it's easier to refer. They do book out really far, you know, as far as 6 to 8 months. So knowing who they are, knowing if you can call and even just have them give a handout for a patient to work on things before their first visit, can make the world of difference for a patient. Go to the next slide. Okay, I'm going to talk about hypoactive sexual desire disorder. You know, this used to not be part of my screening when I was talking to patients of perimenopausal ages, but now I do, because there's so many things that we can do about it, and it can really impact someone's quality of life and cause a lot of distress for a person, for them as an individual, for the relationships that they have, and may even create a lot of fear and anxiety about starting a new relationship. So the definition is persistent absence of sexual desire, receptivity, causing marked personal distress, and affects about 10% of adult women. And it's the most common female sexual dysfunction, peaking during midlife. The distress criterion is essential. Low desire without distress is not hypoactive sexual desire disorder. So the diagnosis is clinical. You do a biopsychosocial assessment and exclude relationship issues, depression, make sure there's no meds that are contributing, no medical conditions. And then really big thing to know, also misnomer, people will check testosterone. We do not need to check testosterone to make a diagnosis. ISHWISH has a stepwise management. Step 1 is education modifiable factors, addressing relationship issues, stress, body image, sleep, mental health, review medications that could be contributing to it, treat contributing conditions like depression, GSM, and dyspareunia would be definitely a big cause of it. Step 2 is psychotherapy, so CBT, mindfulness-based therapy, couples therapy, sexual skills training, mindfulness-based CBT, is really critical here. It significantly improves total sexual function and desire scores in a 2025 meta-analysis. And I'm really excited because now there's a step 3, which is pharmacotherapy, and it's guided by your menopausal status. So if you're premenopausal, you can give medications that are FDA approved, like flibanserin, which is called Addyi, and bremelanotide. I forgot the brand name. I think I have it on another slide. For postmenopausal women, you can give transdermal testosterone. It's important to know there's no FDA approved female formulation. So you will be ordering male testosterone, and you just have to change the dose for what's appropriate for a postmenopausal female. And then off-label, you can use bupropion, especially for SSRI-induced dysfunction. We'll go to the next slide. So premenopausal, if anybody has seen it, there's a documentary about trying to get the FDA to approve Addyi. The first one is called The Pink Pill. Amazing documentary, very interesting if you want to know about the challenges of getting medications for women approved and all the challenges and barriers. It's a really fascinating story and really shows the grit of some people that were trying to be activists in getting this approved. And then the other one is Vyleesi, which is so both of these medications improve desire and distress. The first one, Addyi, side effects include somnolence and dizziness. You have to avoid alcohol within 2 hours of taking it. And then Vyleesi is a melanocortin receptor agonist, improves desire and distress, but doesn't increase satisfying events. Side effects include nausea, flushing. It's injectable, and you can get it from a specialty pharmacy only right now. For postmenopausal women, you can give a fractionated dose of FDA-approved male transdermal testosterone, so 1% gel. You give 1/10 of the male dose, about 5 milligrams topically daily. And then for monitoring, you monitor your the patient's baseline total testosterone, recheck at 3 to 6 weeks, and then every 6 months. And the big thing here is you just want to watch for androgen excess, so acne, hirsutism, voice changes. Trial it for 6 months. If there's no benefit, then you would go ahead and discontinue. You can discontinue it sooner than that, but it may take some time. And then for LGBTQ considerations, you know, HSDD treatments were studied primarily in cisgendered women. Evidence in gender diverse patients is extremely limited. Sexual minority women may have different frameworks for desire, so you want to avoid heteronormative assumptions and then proactively screen for sexual concerns in all patients. And then for testosterone delivery, oral testosterone, you'll want to avoid it in adverse lipid effects, pellets for the reasons we've mentioned already. Injectable testosterone, I would avoid it for these patients because they need such a low dose that a patch or a gel would be better. And then systemic DHEA is not effective for hypoactive sexual desire disorder. So the next slide. All right, postmenopausal preventative health screening.
All right, so I think we've beaten cardiovascular risk aspect already. So, and as far as breast cancer goes, obviously mammography starting from age 40, the only main change, like it's biennial screening. What's changed is that they are no longer recommending a supplementary screening for dense breasts. That's the most recent change. Cervical cancer screening, the main changes now it's they recommend doing a HPV screening Q5 years through age 65, past 65, if until they've at least had 10 years of all normal screens, either 3 negative screens or 2 negative co-tests in the last 5 years. And colorectal cancer screening. Average risk patients, age 45 to 75. You want to ideally colonoscopy, if I can convince them, otherwise at least FIT or the Cologuard. But with the FIT and Cologuard, obviously, if something is found, they have to go get the colonoscopy done. And if there's any reasons for my patients, anything in their family history or constipation, I would encourage them to get a colonoscopy earlier because of the significant uptick in younger patients with colorectal cancer. So if there's any reasons I can get them in for a colonoscopy earlier, do it. Next, yes, lung cancer screening, no changes, but basically like do low dose CT if they're a former smoker or with 20-pack year history in the last 15 years. The other one as far as osteoporosis goes, please, I know the recommendation is at age 65. It does not cost that much to get a DEXA scan, and it is good to catch it earlier because then you have a better chance of affecting bone density. And in our medical literature, it does not show. I don't know why there's not enough studies showing, but at least with patients who are working on this, since I've had an interest in the exercise and gone down that route, patients are seeing a reverse in their DEXA scans if you work on weight-bearing exercise. It really does reverse and go up. Everything that we're taught is that basically after 30 is all downhill. It all goes down. But it does. Your muscles and bones respond much faster than your ligaments and tendons. So ligaments and tendons are the ones that are more limiting, but and we're going to go into that more in detail. As far as mental health goes, in our recent times of having more and more social isolation, of being on the screens, and our society changes our society, we need to screen for more of the mental health conditions because they're becoming more and more prevalent across all ages. That's it. Next.
Okay, let's talk about osteoporosis and bone health. Okay, because I'm a nerd, we're gonna do the nerdy stuff first. So in estrogen deficiency, we've got an increased recruitment and activation lifespan of osteoclasts. So remember, the osteoclasts are the ones that eat bone, osteoblasts are the ones that build bone. So you have an increased number of depth of bone resorption cavities and accelerated bone turnover. You get decreased bone formation because with lower estrogen, you have increased osteoblasts, apoptosis, and increased sclerostin. And then you get decreased renal tubular calcium absorption, so you're losing urine calcium, or you're losing your calcium in your urine. And then you get increased ultrafiltrable calcium, also leads to increased urine calcium loss. So you've got this perfect storm of a remodeling imbalance, right? Increased cavities, decreased osteoblast activity, high turnover, and urine calcium loss. That leads to accelerated bone loss. Go to the next slide. All right, so when, is that the next one?
No, sorry.
Okay. Is there one more? No, okay. Okay, so when we talk about osteoporosis risk factors, I love that Dr. Nachiappan brought up that waiting till 65 for women is very late in the game. So when we think about risk factors, we're talking about parental history of hip or spine fracture. If you recognize these from the FRAX assessment, a lot of these are from there. Low body weight, so less than 127 pounds. You'll notice that it's based on how much someone weighs and not the BMI. So a BMI could be normal, but if they weigh less than 127 pounds, their risk goes up. Current smoking or excessive alcohol use of 3 or more drinks per day, prior adult fracture, and then secondary causes. So premature menopause before the age of 45, or primary ovarian insufficiency, glucocorticoid use, aromatase inhibitors, MPA, anti-epileptics, rheumatoid arthritis, type 1 diabetes, type 2 diabetes, hyperparathyroidism, malabsorption, chronic kidney disease. I think it's really important to note that, remember, estrogen deficiency causes all these problems, but we also know the average age of menopause is 51. So the fact that we're screening for it 14 years later means that we're catching it when it's too late, when we can actually do something about it. So we'll go to the next slide. I get a lot of questions about the fracture risk assessment tool or the FRAX calculator. And I see it misused a lot. So that's why I wanted to put a slide specifically into this. So the FRAX calculator is perfect for your patients with osteopenia. So if you do a bone density, they have normal bone mass, you don't need a FRAX score. In some cases you might want to do one, but for most cases you don't need one. They have osteoporosis, you don't need to do it. This is your osteopenia tool to determine if you're going to treat it or not. So the advantages is it helps identify patients to treat where we have limited evidence of treatment efficacy, so non-osteoporotic patients. The limitations are that it only incorporates your formal neck bone mineral density, and it doesn't include fall-related risk factors for fracture. So you'll notice in all the screenings, it doesn't talk about someone's fall risk. It doesn't apply to a lot of situations like young adults less than age 40, when there's rapid bone loss is anticipated, like early menopause, stopping hormone replacement therapy, hormone deprivation therapy, or getting glucocorticoids, or in secondary osteoporosis. But it does take into account the secondary osteoporosis by some of the questions that I asked. I'll go to the next slide.
And we are at 6:40, just so you know.
Okay, thank you. Okay, so our DEXA scans, I always put pictures of it because some of our younger people may not know what it's like to get a DEXA. And I only know because I've gone to observe it when I was in fellowship. But I think it's good to know so people can see it's not a big scary test. I think a lot of people have test anxiety. And so I think it's helpful to show them what it looks like and how easy of a test it is. And as Dr. Nachiappan said, they're very affordable. So even insurance not covering it might be a reason for some people, but a lot of people can afford them because of how affordable it is now out of cash pay. So we look at T-scores that compares to a healthy young adult. And that's comparing postmenopausal females to men greater than age 50. So -1 or higher is normal, -1 to -2.5 is osteopenia, and -2.5 or lower is osteoporosis. And then the Z-score is how many standard deviations from an average person your own age. So we use this for children, premenopausal women, men less than age 50. If it's above -2, it's within the expected range. If it's -2 or lower, then that suggests possible secondary osteoporosis or something else is going on. We'll go to the next slide. Okay, so when we talk about osteoporosis, I always go into non-pharmacologic therapy first, and then I go into pharmacologic therapy because there's so many non-drug ways that we can deal with this. So one is vitamin D. We like to maintain the serum vitamin D above 30, and our preferred range is 30 to 50. The higher, the better. Higher doses may be necessary in patients with obesity, malabsorption, transplant patients, certain ethnicities, and older individuals. I always like to tell people those of us with dark skin need more vitamin D supplementation than those of us with lighter skin. And then if someone has obesity, you will probably give more than the 2,000 international units a day to help them maintain higher levels of vitamin D. Calcium, we recommend to maintain adequate dietary intake of calcium. I'm learning by counting the calcium for my patients how so many patients don't get enough calcium in their diet. So I like to keep little handouts of common foods and their amounts and how much calcium is in it so that they can have like a rough idea of how much they get without supplementing. Limit alcohol intake to no more than 2 units per day. Avoid or stop smoking. I'll leave the active lifestyle for last. And then really a key thing is reducing the risk of falls, especially among the elderly. So I always tell people, hey, can you go through your house with somebody who doesn't live with you and look for all the possible things you could trip over? The big ones to think about are like your dogs or your animals, changes in flooring. So when it goes from carpet to flooring, or if there's like a ridge, really have somebody who doesn't live with you go through and identify all the problem areas so that you can see if so that the patient can see if that's something that they can address long-term, or if it's something that they just need to be aware of so they can be extra careful. I always tell them to use things like night lights and not to be afraid of them. There's really cute ones that don't look like kid night lights. I love the kid night lights, so I would probably use one of those. And then don't be afraid to refer for physical therapy. That can reduce discomfort, prevent falls, and improve quality of life. It is so hard to refer people for physical therapy because they view it as preventative in these cases. So I just try to tell them, something that might help them. I might use motivational interviewing to see what it could be from physical therapy that they might actually like doing. And the last one is maintaining active lifestyle, and I will hand it over to our certified personal trainer physician.
Thanks, Guari. I just want to, I know we touched on this already, and like you said, a DEXA costs $50 to $100 cash pay. It's nothing compared to what you can do about this, and because only when you know about it, you can do something about it. And you need to start very early for bone health, probably in our 20s, before if we're reaching a peak bone mass in our 30s. So what we want is the high impact exercises ideally, but that's group 1. And then group 1 or group 1B, they split it up, but it doesn't have to be as high. Impact is not as difficult as you think it is. Like just doing jump roping, 10 a day. You don't actually need a jump rope. All you just have to do is pretend to jump rope. And there was a study that was done in England on like 1,000 older males for jumping on one leg for 1 year, for 12 months. They just had to do 50 jumps on one leg. 5 sets of 10. That was it. So the other leg was their control. And 1 year later, there was a 7% increase in that hip that they jumped on.
Wow.
That was it. It was 2 minutes with 2 minutes of exercise of just jumping 10 times with 15 seconds rest in between, 50 times on that one leg. And that itself was enough to improve their bone density, and mortality rates from a hip fracture are like 30% in the first year. But when you can do something as simple as that, it changes people's lives. And this is what is important to do. Like, these are simple things that you can recommend, and it changes somebody's life. So yes, this goes into more things. With the retired physicians, we went over some of the safer things like using resistance bands, and they told me somehow like you could still hurt yourself with resistance bands, but still, you can do very simple things that can help with bone mass.
Okay, one more slide on osteoporosis. So when we talk about pharmacologic treatment, our first line of therapy is bisphosphonates. Second, only because of time, I'll go through this quickly. Second choice is denosumab, especially for patients with renal disease. Big thing to know is that you have to follow it with bisphosphonates before you discontinue them. For really high fracture risk or really severe osteoporosis, you want to use anabolic treatment to stimulate new bone formation. So we've got several options there: baloperitide, teriparatide, romosozumab, followed by anti-resorptive therapy like with bisphosphonates. There's raloxifene. It's the only serum approved by the US FDA for osteoporosis treatment. Estrogen is and so a big thing I want to mention is that estrogen is recommended for vasomotor symptom treatment or other indications. It's not for osteoporosis treatment alone. And then monitoring, you'll want to make sure you get a baseline DEXA and repeat every 1 to 2 years until their bone density is stable. We recommend same facility and same machine preferred. Obviously, that's not always possible. And then successful treatment of osteoporosis is defined as stable or increasing bone mineral density with no evidence of new fractures or fracture progression. I am really speeding over this. My normal osteoporosis lecture is like 2 hours. So just know there's way more to this, but for time, that's what we'll do. Yeah, whole other training. Go to the next slide. All right, skin health.
So, again, for time's sake, yes, this is the cross section of the skin. We can skip up next slide. And basically with menopause, you get a thinning, as you can see, which results, you lose subcute fat. You lose about 30% of the collagen and elastin in the first 5 years of menopause, and then around 2% per year after that. So this is what leads to the skin changes we notice with menopause. Next, going to the treatment, is that, I know I wrote, you want to have sun protection with at least SPF 30 or higher, but almost the studies show that anytime you can use a hat or a long sleeve, something else, clothing does much better than any SPF if you can do it. Unless an area cannot be covered, it's better to use clothing because it's it stays on and you don't have to keep reapplying. And use mineral sunscreen. Next, antioxidants help reduce the free radicals, vitamin C. So you normally want to use this in the morning, like sun protection and the vitamin C in the morning for brightening of the skin. Then you want to be replenishing the skin barrier with thick moisturizers. If it has ceramides, peptide-rich emollients, and then hyaluronic acid also for hydration, plumpness. You can do that morning and evening. To increase the cell turnover, you would use any type of retinoids at night. And then you obviously have to be more careful with sun protection if you're using retinoids. And then you want to do double cleansers, usually like an oil-based one, like micellar water, and then a water-based cleanser for deep cleansing and hydration, and not soap. And other good practices would be avoiding fragrances to avoid irritations, improved sleep, and obviously for skin health is not the reason to do systemic hormone therapy, but if you do, that is also going to help. And then there is currently no evidence I see, but the other option is Astral Plus creams that you can use topically. I don't know if you have any more.
No,
No,
I
I
think
more evidence than, okay. It makes sense that it should help. It helps with vaginal estrogen creams, but just instead of having even more than having a complicated thing, just any basic moisturizing daily routine that you provide for your skin will help it in the long run. The better you keep it moisturized, the less it's going to age, less wrinkles you're going to have. And obviously visit your friendly dermatologist.
Okay. So before Dr. Nachiappan closes us up, I just wanted to, we just want to summarize kind of a big picture way to look at menopausal transitions. So step one, confirm menopause. That's a symptomatic diagnosis or clinical diagnosis, not through labs. But you want to make sure you rule out thyroid, pregnancy, and other causes. Assess hormone therapy contraindications. Identify the symptom type and the appropriate hormone therapy you'd want to give. Step four, I divided into vasomotor symptoms and genitourinary syndrome of menopause. So vasomotor symptoms, make sure there's no contraindications, and preferably age less than 60 and within 10 years of starting menopause. Like I said, there are some exceptions to that, so please don't be black and white about that. For hormone therapy, If it's contraindicated or patients prefer not to start it, then you've got SSRIs, SNRIs, gabapentin, all the things that Dr. Nachiappan recommended. And then for GSM, for mild, you've got over-the-counter moisturizers and lubricants. And then for more moderate, severe vaginal estrogen, DHEA, et cetera. And then step 5, reassess. So just make sure you're constantly checking, because like I said, on that one of those earlier slides, that continuum of symptoms changes. And so it's important that we check in. I think reassessing at 12 months is actually a long period of time. I like to check in a bit more frequently. And then use the minimum effective dose and make sure that you're evaluating if there's a continued need, side effects, that kind of thing. And then don't forget our contraindications, and make sure that you talk to your patients about those.
All right, and like we talked about at the beginning, if you celebrate the menopause transition, have a ceremony, just like, hey, you have a birthday, you have a ceremony, invite people to celebrate this milestone that you've achieved it. You've been lucky enough to reach this age. Create a symbolism, you have a piece of jewelry, something, or leave a time capsule for your family to find, take a bath, whether it's nourishing or spiritual. Baths usually have that. And then other restorative practices, meditation, yoga, tai chi, anything that helps you take better care of yourself, to renew and restore yourself. Doing something like a journal to reflect on your past and present will help you understand where you are, what you're going through, so you can make better decisions, which brings you to, hey, what are the next steps? This gives you a moment in time to reassess, where is your life? What do you want to achieve? It's like, hey, so pause in your time to be able to find purpose and formulate what you want to accomplish in the rest of your life. And obviously schedule more doctor visits to take care of yourself, preventive care, and celebrate, and make sure you connect with others to make this a celebratory time. All right, and have your own special time. So I know we had a picture of astronaut working out in space. Just a moment to realize, hey, normally they picked, look at who was chosen to go on the last Artemis trip. The youngest was Christina Koch. She's 47, and the rest are older. So this is, instead of thinking of menopause as the end, they picked us the prime and wise ones to go there. So any questions?
Are you ready for a question?
Oh, takeaways.
Yeah. We won't go through takeaways. We'll leave it open for questions.
Yeah.
Go ahead.
Hello, can you comment on propensity for kidney stones versus calcium treatment for osteoporosis?
Golf balls, car wash.
Treatment for osteoporosis.
Oh,
We've got kidney stones from calcium supplementation.
oh yeah. So this is a good question too, because they actually also came out with increased coronary artery calcium scores in people with calcium supplementation. So I always tell people to try to get your calcium from your diet. The less we can supplement, the better. So if patients are getting that, I would just make sure they get the 1200 milligrams from their diet. If they are, you don't need to supplement with calcium. That's where we're seeing a lot of those kidney stones and things like that. And if you think that they might have an underlying pathology, definitely either do a workup or send them to endocrine. We love that kind of stuff.
And then also calcium citrate is the best for absorption, where you don't have to have it with a meal. You can take it anytime and it will be absorbed if you're taking a supplement. So, but I do find it's a little bit challenging to get it just from your diet, unless it's
It is
a
hard.
diet, drinks
Mhm.
have added.
It's especially difficult for people who are dairy free.
All right, we have a question from Dr. Stephen Perlmutter. If average menopause age is 51, why don't women in their mid to late 40s get pregnant?
What?
Why don't women get pregnant that often in their 40s? It's menopause.
Oh,
at 50.
That's a really good question. So don't forget, part of the workup for menopause is we check for pregnancy. But fertility is such a big, complicated thing. It goes so much more than what's happening hormonally. Would that be okay? Could we do like a follow-up on that one? Because it is a big.
Yeah, but also like, I mean, technically, girls get their periods at 11 and 13, but you're not really, your body's not set up to grow or pass a child successfully at that age. It's a, you know, it's a bell curve. So the curve is going down. So yes, it does happen, but it's not ideal because the peak is.
Yeah, and don't forget the hormonal changes are starting way before menopause. So that we're talking about the last 12 months after your last period being the average age of 51. But the age range is actually 45 to 55, but then those perimenopausal changes are happening as early as your late 30s.
And do we have more questions from our audience on virtual? You can unmute yourself if you have a question.
Yes, has the osteoporosis increased in people with the HRT if they're in the 50 and above age group, and any issues with the use of HRT if they're on the GLPs and or any of the SSRIs that are not the ones you mentioned that have a specific value?
3 questions.
Yes.
What was the first? Can you give me one question at a time? What was the first one?
The first one is the issue of if you're on a GLP, has there been an increased incidence of osteoporosis if they're on HRT? Or is there a risk to putting them on HRT if they're doing the GLPs and they're in the 50 plus range and they're actually losing significant amount of weight?
Okay, if obviously with the GLPs, this is a real-time experiment that's happening for long-term studies. We do not have long-term studies on all of them, but physiologically, it makes sense that they probably going to have risk for osteoporosis because I know many patients come and they want to have rapid weight loss where they're having malnutrition because the amount of calories they're consuming is much smaller. And I know it's even more important. The quality of the nutrition is even more important. But I can see, I have many patients on this and I find out accidentally when they let me know like, oh, I have them start on the weekend, but then they keep delaying it and don't take it on the weekend because then they want to eat 2 slices of pizza. Normally they can't on the GLP, they can only barely have a couple bites. So then they try to they're not necessarily getting the best nutrition.